I'm very thankful to all my national and international faculty to be here and give their latest opinion. Besides having the lectures, as you see, we have put in the debate form and the short lectures. You are asked to, allowed to ask, actually, we encourage to ask the questions, and moderator, they will show how you can ask the question by the, you can send the question to the panel, the moderator here, and will answer those questions in an appropriate, timely fashion. So now, with that note, we start our usual top 10 advances of 2018, which I always start with paying tribute to Andres Gunzig. Because of him, we are here. A dream always was the catheter-based percutaneous treatment of vascular disease in alert and patient, which I added with utmost safety. This is what the interventional cardiology has become. So idea is, I present the data of the year before. Those have really revolutionary the trials, abstract, or some the discovery, which have led to our change in clinical practice. So we start with the first one. That is the recurrent DES ISR. Clearly, the DES are here to stay, decrease the restenosis of coronary interventions, but clearly they still have trouble. So, and many of them, many mechanisms have been eluded with biological, mechanical factors, the technical factors, and so. But overall, it's the intimal hyperplasia which really caused the restenosis, and there have been a difference in the BMS and DES in terms of histopathology and the diffuseness and focal disease, more of a focal in the DES. And of course, the various technique, whether you do a bare metal or you use a drug-eluting balloon or you use a drug-coated balloon, and those all have been shown to be beneficial for the DES ISR. So, but of the wide variety of these interventional technique, so a lot of work has been done in using the drug-eluting balloon for DES ISR. This is the data from the RIPS-4 at three-year follow-up. It seems to be that if you compare that with the everolimus eluting stent, so you see the EES is better in the earlier trial compared to the drug-eluting balloon. The DARE trial, the latest one with the paclitaxel eluting balloon versus everolimus of patients, about 300 patients, and you can see the outcome kind of similar, which is the drug-eluting balloon and the drug-coated balloon. So clearly the similar DES versus DEB, a similar outcome, but always still I would say the DES remained slightly numerically better. So then the question is, what about you use a scoring balloon before using the drug-eluting balloon? And it showed this study, I said Desire 4, that a scoring balloon before the drug-eluting balloon was superior compared to regular balloon angioplasty. And that is what we do. We use a scoring balloon. The brachytherapy, which was initially done and then compare against DES, clearly failed. So clearly we started using the DES for the restenosis of the bare metal stent. But now it has come back with a second wind because we are putting a DES ISR. You put another DES ISR again, then what you do? So this is we started this technique in 2012, being a third center at that time for IVBT. At present, with the data and use, about 59 centers in the country are using IVBT for DES ISR. We reserve that for patients who have at least two ISRs already, two drug-eluting stent already, and then have come back. So these are what we did is our own database, patients who got IVBT, about 187, compare with a non-IVBT arm. Those all have at least two layers of stent. Majority of them Marantz type 2 to 4, diffuse restenosis. And we know these patients do poorly. And what we saw, event rate reduction from 46% to 18%. So no late thrombosis and no restenosis, no restenting at the time. So key is that yes, the IVBT did very well. These are the individual endpoints. And we are going to present in next few months, 3-year follow-up of these patients. So what we do now, the drug-coated balloon will be good for smaller vessels, bifurcation, restenotic lesion with multiple stent layers. The re-DES may be preferred for the large vessel, particularly when you have a one DES or stent fracture, and patients who have multiple layers, 2 layers of minimum, the IVBT is recommended. The second is the calcific lesion. Calcific lesion always a trouble. because of the inability to stent for expansion, higher complication, dissection, and poor apposition, and of course they have high restenosis. So many of the devices which have been suggested, and particularly the atherectomies, and we have now another randomized trial for calcific lesion, which is called Prepare Calcium, which compared the scoring balloon versus rotational atherectomy. Same group which did a few years ago the Rotexus trial using a balloon angioplasty versus rotablation before paclitaxel eluting stent. And here, the Orsiro stent was used and basically showed in the patients about the 200 patients that if in the calcific lesion you don't use a atherectomy, about 16% time you have trouble. You have to use it, crossover will occur, sometimes stent loss, and you may not be able to deliver the device. Overall, the 9-month outcome was not different, although numerically you can see rotational atherectomy has a lower event rate, TVR and TVF, compared to modified balloon, but the statistically was not significant because of a small number. If this same thing happened for 500 patients, would have been significant. The other thing which have been a slight higher late loss in the rotational atherectomy group, we actually was not significant, but you see here, still there was about 0.06 higher late loss with rotational atherectomy, which has been an issue for us in terms of restenosis with the rotablation. We have our own data to compare rotational atherectomy versus orbital atherectomy in 1,300 plus cases, consecutive cases, and basically showed that what we found in our data that orbital atherectomy from procedural point of view had a slightly higher dissection and perforation. There was no other difference in terms of CK release or slow flow, although historically it has shown slightly lower slow flow with the orbital atherectomy and the outcome. This is an unadjusted outcome of clearly favoring, which is the rotational atherectomy versus orbital having a lower event rate. But once you make adjusted, the difference decreases but still remain that there is a lower restenosis with the orbital atherectomy group compared to rotational atherectomy. So that phenomena, which is seen basically that rota still remain higher restenosis, we also noted in our group. What also we saw that orbital atherectomy, actually this may translate into a lower restenosis, better stent expansion, and less percent of malopposed struts, because stent really expands after orbital atherectomy. There is still a randomized trial being planned to compare these two techniques. Then imaging in the cath lab, many of, we all know that angiography, then of course the OCT, IVUS, all have been used in the lab along with the NIRS, which we have a lot of data by Dr. Keeney on by Yellow, and then using the FFR and IFR in the cath lab now become gold standard that for PCI, to do PCI or not to do PCI, but clearly we really need a trial which show that by using the imaging routinely, you're going to improve the overall outcome. So there are few publications last year. One is the Pan-London PCI cohort, and basically showed that about 12% they use IVUS, OCT in 1.3%, and basically showed that by using the OCT and IVUS, you're associated with lower in-hospital MACE and mortality. More importantly, at a follow-up, that this is the angiographic outcome, 15.7 in about a 5-year follow-up, which decreased to 12% in the IVUS and OCT by the OCT 7.7. You say, well, that's a dramatic difference. But remember, OCT was done very selected patient in 1.5% of cases only. But whatever the data are, that imaging decrease the overall the MACE rate at follow-up. So it makes sense. So towards that, there are few, these are basically subsequent data. There are some randomized trial, one of them being Ultimate, which is the IVUS guidance versus angiographic guidance in 1,400 patients, and basically showed that by using the IVUS, you get a better and bigger lumen, as you can see here. But a lot of people believe that using IVUS, you'll have a lower procedure time and contrast volume, and that is not true. Anytime you do IVUS, you'll have a little more contrast volume and procedure time will increase, but look at the outcomes. Target vessel failure was 2.9% with IVUS guidance, 5.4% with the angiographic guidance. This paper was just published in JACC, that reducing the event rate by half. There's also a decrease in stent thrombosis. So it makes sense that routine IVUS, particularly in complex cases, may be beneficial. The real answer will be from the OCT, Illumin 4 by Ziad Ali, our former fellow. He's done a great job of directing the imaging at Columbia at present, which is complex cases, 2,500 patient OCT guided versus angio guided PCI, with the outcome being 1 year target vessel failure. So really will give us an idea that large series of patients, whether you need the OCT, will improve the overall outcome. What continue to remain is the one intervention done with the FFR. So even 5-year data of the FAME2 trial continues to show the superiority of the FFR-guided intervention versus with a good outcome at follow-up. The question always comes, what about using the FFR deciding for coronary artery bypass grafting? We actually have the randomized trial, the Fargo trial. Basically, they did a patient's FFR and then brought back 6 months after the bypass, and then patients were deferred if the FFR was more than 0.8. So a little surprising that patients who came back, you can see here at 6 months, at the deferred lesion, many of them became significant. If you take a FFR of 0.8, all of them were about 0.8, but look at the some percent of cases become lower. And the graft occlusion was not different, but basically the conclusion was the FFR-guided CABG had similar graft failure and clinical outcomes in this angiographic-guided CABG. However, FFR was reduced significantly after 6 months in deferred lesion. So the question is, there are a few other trials going on in this field, but I think FFR to be used only in rare cases where they are not sure that whether that vessel should be bypassed. And classical case being, you have very complex lesion in the circumflex and RCA, and now you have about 60% hazy angulated lesion in the LAD. Should you do a lima? And of course, we'll have a lot of discussion about those type of surgery should be done with Dr. Puskas being here and will be with us today and will present the data. The bifurcation lesion intervention, and this is actually with Anu's forte, various app, but particularly bifurcation was the first one because we have so many techniques, so many devices to use, whether side branch or not side branch. So bifurcate app, which was released last year, basically started with whether you have left main or non-left main disease, because our strategy is totally different in left main versus non-left main. Why? Because in the non-left main, by and large, we do one stent approach. In the left main, 2-stent approach as shown by DK Crush and many other studies have shown to be superior to a single stent approach. So this is what basically we do. This is one of our monthly webcast, distal left main disease, that how you use this technique or app while you're doing the procedure, and you can actually show side by side what is shown on the app, exactly the steps very well shown, whether stent deployment, then recrossing. It goes through all kind of scenario and very educational tool for interventional cardiologists. This is the final angiogram. So this bifurcate app actually available both with app as well as on Android. They published the data of the overall educational towards the global cardiovascular education, and it has been a 10,000 plus download. So one of our most successful app, very useful, and of course we soon will be coming up with the update on this bifurcate app. Then the newer DES and the drug-coated balloon trials, there are a few of them. One is the talent trial presented by Patrick Soroy last year in TCT. It still has not been published. Is by using a Supraflex SES, made in India, biodegradable polymer, cobalt chromium stent, and sirolimus drug. Again, a thin, lower concentration of sirolimus compared to what used to be done in the Cypher, and compared in 1,400 patients, basically showed that Xience actually was superior in terms of success. So Xience still remain on the top in terms of device success and procedural success, but the overall outcome, the MACE rate and target vessel failure was identical at 12 months follow-up. There was slightly higher the mortality, which is not clear why that happened in this group of patients. What about using the drug-coated balloon for the small coronary arteries where stents are not great? And this is the trial, Basket Small 2, which compared the drug-coated balloon with a drug-eluting stent and basically showed that overall the target vessel revascularization and myocardial infarction were identical, but you see the signal, mortality, This is the drug-coated balloon, and this is the drug-eluting stent. There's slightly higher mortality, so whether this is similar phenomena what they saw in the peripheral need to be seen. There is another trial which is seen here using the synergy stent with the abbreviated DAPT of 1 to 6 months, comparing with the DES versus BEMS, and it seems to be that DES is still with the abbreviated DAPT is better than compared to bare metal. So bare metal, these are the patients with more than 75 years of age. So clearly seems to be that bare metal are not even the notion that bare metal will have lower thrombosis is no longer true. So we use 99% or 98.5% cases of a DES. Very rare case of the bare metal. We'll use like patient need to go for surgery next week and so. But otherwise, after 1 month, there are many of the short DARP studies are ongoing at present that you can stop safely in many of our current generation DES, that clopidogrel after 1 month. Then PCI and CABG data after 5 years. We have syntaxes, freedom, follow on, and main compare. So basically we knew that 5-year data by overall CABG versus PCI with the put all the trials together, that lower more so in the diabetics versus non-diabetic superiority of the CABG. And we know so far CABG, of course, lower repeat revascularization, durable angina relief, and then of course PCI, rapid recovery, lower CVA, improvement in LV function. The question comes, what you do in what are the data after 5 to 10 years? Because many patients, or majority of the patients, live more than 5 years. So we need to have a long-term data. Clearly, the PCI has shown that if you have the syntax score is high, then CABG is better. But if syntax score is 32 and below, PCI and CABG, even present data are similar. So these are the 4 trials which were presented last year for more than 5 years of follow-up comparison with the PCI versus CABG, Lehman's, Freedom, Syntax, and main compare. And Lehman's basically trial showed, this was a trial always favored even early time, the PCI, because this was not a right appropriate CABG trial, because Lima was used in 64% of cases, and what it showed basically better improvement in ejection fraction after PCI versus CABG, and of course the 10-year data shown here. Then Freedom follow-on done here under Dr. Fuster's guidance with 89% follow-up rate, and it shows that with extended follow-up, even after 5 years, the difference 18.7 versus 23.7 with the p-value of 0.07. So key is that curves still continue to favor the CABG compared to PCI. If you take all the groups, it still remains the same. So seems to be that whatever benefit we always used to say, maybe after 5 years we'll catch up from the PCI point of view because graft failure occurs. But the data showed with the Freedom follow-on, that doesn't happen at 5 years. Will it happen after 10 years? We don't know yet. But we have the 8-year data. One thing very important came that patients who are younger group, that really derive the statistically better benefit of the CABG compared to the PCI. Then with the Syntax trial, with a 10-year follow-up, overall, the 5-year data, as you can see here, the MECI, as well as all-cause mortality, always favored the CABG, although not necessarily in the entire group, but lower MACE event with the CABG compared to PCI. And now we have the 10-year data, that 29.4% with the PCI, 25.6% with the CABG, with a p-value of 0.1. So same what was seen at 5 years. But what more important was that really statistically difference in the 3-vessel disease, not in the left main. So and there was no difference in diabetics. So 3-vessel disease, although diabetic, not difference in this syntaxis trial. But CABG superiority overall, and particularly patients who have the high syntax score. As you can see here, odd ratio favoring CABG, patients with the high syntax score. So what observation noted at 5 years continue to hold true at 10 years with the syntax trial. Then main compare, which outcome of this is more of a registry, stent versus CABG, similar data that even after 5 years, target vessel revascularization is higher with the PCI group compared to CABG. And so then question always comes, what about in the complex disease, various stents. We actually have the data from the Korea IRIS-DS trial of the 2,000 patients, and it shows that all stents kind of equal, except they found the platinum chromium had a slightly higher target vessel failure compared to others, but overall seems to be our strategy, complex complex CAD going for the cabbage, and less complex going for PCI remains true. So then, radial intervention. We already have a lot of data of the radial. Now we have the 1-year follow-up of the matrix trial, which compared radial versus femoral, bivalvulotin versus heparin. 30-day data were presented earlier, and then we have 1-year data for matrix showing access point of view that radial is associated with lower event rate, 15.2 versus 17.2, with a p-value of 0.01. So radial continues to, in acute coronary syndrome, beneficial compared to femoral. And these are the individual endpoints. No difference in death, but definitely cardiovascular death, and of course, the bleeding. Now, there are some concern whether radial has higher stroke rate, but in the matrix trial, there was no difference in stroke rate as shown here, and nor in the myocardial infarction. As far as the antithrombotic therapy, unfractionated heparin or bivalvulotin, there was no significant difference, and that actually changing the guideline in Europe. They have not updated the guideline, making radial as a class 1 indication at present in United States. Although there is another trial which was presented this year, it may change with the recommendation comes, which will be coming soon. Then multivessel PCI and cardiogenic shock. What does that mean? Basically, we had taught over the years with the trials that in STEMI patients, we do a non-culprit vessel PCI, full revascularization is better than culprit vessel. But now, what about the shock? Always was taught without any data that shock patient, you should open every vessel. Well, this actually has been put to the task that is that true? The patient with a shock trial, that you do culprit vessel or do a full revascularization, and 1-year follow-up is showed that renal replacement and mortality, as you can see here at 30-day, the favors your culprit vessel versus the full revascularization. What about at 1 year? 1 year remain the same way. So this is the event rate in the culprit vessel is 52% versus 59.5% in the multivessel PCI. So it seems to be that culprit vessel PCI in shock patients is the right thing to do, and these are the individual endpoints, but overall favoring the culprit vessel PCI, which actually has changed the guideline in Europe. We have not changed it here yet. In the past, the full multivessel revascularization was 2A, now has become 3 based on this data in the cardiogenic shock patient. Now, another concept which has come is door to unloading time. So data have shown that if you can unload the ventricle before you revascularize, you have a less microvascular dysfunction. And it proceeded before this D2U STEMI pilot trial to show that if you can decant the ventricle by putting an impella, wait for 30 minutes before you revascularize, compared to you put an impella directly. And basically showed the proof of concept that there is no difference in by delaying, your infarct size did not decrease. Although numerically delayed revascularization was, the infarct size was smaller, but overall, as you can see here, the infarct size, total mass index, microvascular obstruction in a delayed revascularization, half hour, patient is STEMI, you have put impella, not opening the vessel. Proof of concept showed that it's okay to do it, which had led to the major randomized trial, national trial, which will be starting within 1 month. That is your classical PCI, which we used to do, immediate opening the vessel and no delay, versus you put an impella for 30 minutes and then do the PCI. That will be the real concept, because early trials showed that more ST elevation, more interval MI, you delay half hour, unload the ventricle, you have better outcome at follow-up. Then the inflammation post-PCI, which is the residual inflammatory risk. As you know, besides the lipids, which is LDL, there are a lot of inflammatory markers which have been attributed to bad outcome in our PCI patients, or for that matter, any coronary artery disease patients. And these basically are the various cytokines, and the whole field is ongoing at present, that at various levels in this cytokine arena, that drugs are being tested beyond just antiplatelet, beyond just statins. to decrease the inflammation in these patients. So this field, call it a residual inflammatory risk, which could be based on the CRP and the LDL, and so evolving. So data, the few of the trials, as you know, the CANTOS versus a CERT trial, basically CANTOS was positive, and with the methotrexate, which was using interleukin 1B inhibition, and with the methotrexate was negative. So we actually, with Dr. Roxana Mehran, from our interventional database of Mount Sinai, came up with this concept of the residual inflammatory risk. Does it translate into the outcome? So what basically they did, that patients who have serial CRP values of these 22,000 patients, at least 4 weeks apart, and high CRP is defined as more than 2 milligram per deciliter, and divide in the 4 groups. 1, increase persistent high RIR. So high 2 in the beginning and after 4 weeks. Then increase RIR was low at the time, and then second value was higher. Attenuated RIR high became low. And then lastly, persistently low RIR with less than 2 CRP in these patients. What basically found? That these are the values for these patients, but more importantly, that you can see that all endpoints, the death, MI, the TVR, and of course MACE, so there is a gradient from the persistent high RIR to persistent low. So having a lowest event on this side, highest event in the residual inflammatory risk. So just basically simple test, higher CRP, and 90% of these patients are on statin already. And of course, everybody taking a dual antiplatelet therapy, and these are, you can see MACE and MACE plus, using the revascularization, very clear-cut event reduction at 1 year. So very nicely with a central figure with a 1-year death, MI, so these are the 4 groups. It just shows that there is another marker which beyond just your PCI, which will tell us which patient is going to have trouble in future. So this is actually a nice editorial by Ridker for this paper, talking about both CRP and LDL, that what you need to do to get these risk factors down. So to me, the most important advance of last year was the aspirin duration post-DES as a part of the global leaders. So we all know that you need depth after PCI, after minimum for 6 months. After that, maybe 6 to 12 months you may or may not need, because safety and effectiveness comes. After 1 year, there is increased risk of bleeding. So question always has been that can you interrupt DAPT? If you interrupt DAPT, do you stop the clopidogrel or non-aspirin DAPT group antiplatelet therapy? But concept now in last 2 years have resurfaced that what if that you stop the aspirin, not the clopidogrel or second antiplatelet therapy. And these are the 2 trials, global leaders, aspirin with a ticagrelor 24 months, and then Twilight, which is the 3 months of aspirin and continued ticagrelor. So the global leader was presented last year, and the concept was that give aspirin for 1 month, whether patient has ACS or stable CAD. After 1 month, you stop the aspirin and continue ticagrelor 90 milligram twice a day. Very novel concept. You can imagine for investigators and of course everybody to get ready, because we always learned that aspirin is a must for PCI, but how can you do? And then it was compared against with the reference strategy, that is in acute coronary syndrome, you continue your aspirin for 2 years and ticagrelor for 1 year, then stop. And stable CAD, continue aspirin for 2 years and clopidogrel for 1 year. So that is what our usual practice. This is the usual practice. This was the experimental practice. And you see here, the endpoint was 2-year death and new Q-wave MI. So large number of patients, about 16,000 patients, and you see the compliance point of view, because that was the very important point to see the effect of the therapy, what happens to the patient. So now you see the compliance is very good in the beginning, but after 6 months and 12 months, which you're supposed to get, the ticagrelor monotherapy should be about 100%, only 82% were in this getting ticagrelor monotherapy. At 1 year, outcome was in favor of the reference group in the experimental group with a mortality of 1.95 compared to 2.47. But the endpoint was 2-year death or new Q-wave MI You see here 3.17 versus 2.81, p-value was 0.18. So ticagrelor monotherapy failed to show superiority over our reference or our conventional strategy. Now, one thing which it did show, that the bleeding point of view, there was no difference. So by using this lower abbreviated aspirin, bleeding was not different, but the primary endpoint of the trial was not met. And there was a lot of negative in the media and TCT and everywhere. You see here, the trend was there in the death MI, death, and of course the TVR. But endpoint did not make p-value of less than 0.05. So this was one of the novel concept which was tested, although was not able to meet the primary specified endpoint. Actually, it did very good patients who were more than 75 years of age. That definitely was positive in that, but I took it in a different way. Look at the interpretation of the trial. That is the ticagrelor in combination with aspirin for 1 month, followed by ticagrelor alone for 23 months, was not superior to 12 months of standard dual antiplatelet therapy, followed by 12 months of aspirin alone in prevention of all-cause mortality or non-QA MI, 2 years after PCI. I would say a little different. My interpretation is a little more positive. That is, the global leader has opened the door for future trials of eliminating aspirin after a short time post-PCI to decrease bleeding without affecting the stent thrombosis or MACE. So at least this arena has opened up for subsequent trials, and the major trial, which is done by Roxana Maran here, Twilight, complex patients, 3 months, aspirin, ticagrelor, open label. After 3 months, there is everybody continues ticagrelor as an open label, but then randomized to aspirin or no aspirin with a 15-month follow-up and additional 3 months. So the primary endpoint is the clinical relevant bleeding. And then, of course, other MACE endpoints. The trial has completed. More complex cases were enrolled in this patient and will be presented in TCT. And that really will be the final, I would say, the saga in this proof of concept that by eliminating aspirin, do you do better for these patients? So these are the top 10 advances for 2018, which is the multivessel PCI in cardiogenic shock, bivalvular in PCI, FFR post-CABG, no good, bifurcate app, rotational atherectomy in calcific PCI, and CABG 5 to 10 years plus IVUS in PCI, drug-coated balloon in small vessels, and 1 month of aspirin ticagrelor. I still keep it positive. And real benefit was that the transradial PCI, IVBT, and of course the residual inflammatory risk, which really taught us quite a bit to become the better interventionalist and improve survival. I just want to share our data. This just came out about 3 months ago. New York State presents the data for all the hospitals and the physicians. This is a number for 2016 overall, and double star means that your mortality, 30-day risk-adjusted mortality, is lower than the statewide average, and we continue to receive double star in 1 or 2 categories. This is the volume, being number 1 since 2005. So now for about 12 plus years, we have the number 1 in terms of the interventional volume in New York State, and of course, continues to have a lower complication. And this year, 3 of us got the double star for this, for excellent PCI outcomes. So now for 21 years since the report started, in 1994 and 5, Mount Sinai Cath Lab or interventionalists received the double star designation. Also the lower, the readmission also. Now what has happened is that now interventional, remember in last few years, interventions of various kinds continues to decline. But now understanding better medical therapy, things are changing a little bit. And we can see, this is actually our last 5 months data, that already 17% increase in both coronary intervention and particularly the valvular intervention shown here. The most important, I would say, is the CCC live cases, which will be the 120th episode next week, the 10 years, big educational series, really 8 to 9, third Tuesday of the month, with Samir Mehta moderator. We then added the live peripheral and structural heart live cases. This is a great success. Usually hits per month about 10 to 15,000. Live about 800-900, but then a lot of archived. This is we track it. And you can see the various countries' point of view, USA, India, followed by Germany, very high, and these are the individual the centers. So has been a very reassuring. So I just end up my the talk with this, what we have done with the CCC live cases that really teach the intricate and steps of the techniques of interventional cardiology. And people always ask that, why are you teaching all your tips of the tricks? I said, no, that is the right thing to do. If what we do, we have such a great results and you can duplicate and do a good work and treat your patients, that is our aim is served. I go with this Buddha's quote that thousands of candles can be lighted from a single candle and the life of the candle will not be shortened. Happiness and more so the knowledge never decrease by being shared. Rather, it continues to multiply. The last one, the New York transcatheter valve, which will be on December 5th, separate one-day seminar. Today we will show one case of valve in valve, but all other 11 cases are all complex coronary intervention. Only one case will be of the valve in valve. And I really thank to the cath lab attending staff, cath lab itself, and for this meeting, our sponsors, and Trisha Gaffney, and people who are doing our audio-visual show. With that note, I'll stop here, and thank you very much.